anterior complex is there, right?
Correct, and I think it's a very important point to make, in the sense when you're faced with that situation early in the trimester, if you can't see the CSP, don't jump to a diagnosis. Just go ahead and evaluate the anterior complex. And just to point the landmarks of the anterior complex, this is the midline falx. And if we magnify HD zoom, just like anything we're imaging in obstetrics, make sure your magnification is adequate. We have the point where the anterior horns converge to the leaves of the cavum septum. So these are the leaves of the cavum septum. It's not very well seen, but that is the geno just at this point here. It's hypoechoic. Remember I said it's got echogenic borders and hypoechoic in the center. I call it the sandwich. So coming around here is the geno of the corpus callosum. This is the pericallosal sulcus, and this is the falx forming the anchor complex. And then if you magnify further, these are the leaves of the cavum septum pellucidum. And then if you come back here, what's that structure there?
There is a white one?
Yeah.
White one is
the telachoroidea. So if we measure, when looking at the CSP index, we measure from that echogenic line of the telachoroidea, and anteriorly we include the geno up to the level of the falx. It's important to recognize that the anterior-posterior diameter is longer than the AP diameter. Because if we find that it's the other way around, that the AP diameter is wider than the anterior-posterior diameter, would you be worried about that, and what would you be thinking?
I think, the Nguyen is the most appropriate person.
Good point.
Who can answer that? Yeah, because the wider CSP. The wider CSP, the huge.
So I'm going to pretend, Ewan, that we're doing a scan and that this is the CSP, and I'm going to measure a wide CSP. I'll just try and change my image to make it as much as possible. So I get a CSP, Ewan, that looks like this, and my anterior posterior measurement looks like this. What would you think?
It's really difficult to determine the exactly position to measure the CSP.
Yep. Good point. So I mean, it just becomes difficult. And in terms of partial agenesis, is it more likely to be wider in partial agenesis than the AP diameter? Yeah. Good. Okay. Yeah, let's change the
And
page.
I have one question, because we skip the posterior fold anomaly, and because very common we see the posterior fold about around 10 millimeter, and some authors suggest that we measure on the sagittal plane, not the axial plane, for the posterior megacysta magna. So
Yeah.
in your practice, daily practice, for the posterior fossa, the cysta magna, how can you measure in the
Yeah, that's
axial plane or sagittal plane?
It's a very good point. And just before I leave it, to answer Nguyen's question, is the baby, when we look at it, is in a difficult position to get the corpus callosum. We're not going to do a vaginal scan, but when you come around trying to get the baby into a sagittal position, it is very challenging. So what do you do when you cannot get that sagittal position of the baby's corpus callosum? So you come around, the next thing to do is to use your other hand. Now can somebody come in here and push for me? I need an extra pair of hands. Thank you, just there. So you get an extra pair of hands, and then once you're in that position, I mentioned to you about the sandwich. So what you do is you then next reduce your depth. So the first thing I do is reduce my depth, and then I toggle my zoom. And once I'm in that position, I now can see the geno of the corpus callosum. I can see the singular gyrus. This is the singular gyrus here. I can see the cavum septum pellucidum is not square, it's actually triangular. And I can see the anterior horns converging to the leaves of the cavum septum pellucidum on both sides. I can see the thalamus coming into view here, the caudate nucleus coming into view here, looking for calcifications that you get with cytomegalovirus infection. And I can see the cerebral fourth ventricle, and in there is a tiny little echo, which is the intrathalamic adhesion. And I can see the thalamus on the opposite side, and I can see here is the head of the caudate nucleus, And over here is the anterior limb of the internal capsule passing posteriorly, and then here we have the sylvian fissure. Once I've got the gene of the corpus callosum, I then hold that into position, and then I rotate, keeping that line of the corpus callosum into view, and I rotate on that. Once I rotate on it, it then very predictably brings into view the corpus callosum. What's important for me is when I get this image, is that I keep my vermis in view. Once I magnify the image of the vermis, I then go to my gradient, which I put on max, my dynamic range, which I increase, and then with very gentle motions, I can see the rostrum, general body, splenium, the telea, choroidea. If I come down, I see the tegmentum, I can see the fastigial point, and I can see the vermis. I do not measure this. This is a routine screening evaluation, but if you do want to measure, there are a number of charts. You can measure from outer to outer, or you can measure inner to inner. When I'm in that position of looking at the pericallosum, I can choose color Doppler. I reduce my box until it's a very small size, and I reduce my PRF, increase my color output, and increase my color gain to catch the pericallosal artery. This will give me the branches of the pericallosal artery, but I don't like using color. My preference is to use power Doppler or even slow flow. So when I go to slow flow, I have to pull back on my 2D gain until I reduce it, and then I can see the branches of the pericallosal artery. I do a split screen, slightly increase my gain, reduce my magnification, but my vermis has fallen out of view, so I'm not in the right plane. It's only when I bring my vermis back into view that I know I'm now in the correct section. And once I have my vermis in view, I magnify the image, and then I can take a 3D body map position. And on the body map position, I will ask the patient then to hold her breath. But not until I have the vermis in view, and I can see the full picture of the cadence and unsolicited. So hold your breath. 5, 4, 3, 2, 1. Very long, and breathe away normally. Once it does this, it will give me a multiplanar display, and I only want the A plane, although the super will want to be human manipulation. Time, okay. Finish. So Ritsuko is manipulation. Tell me, Ritsuko, all of the changes that you're making in the pericallosum. Just let her head Is she feeling lightheaded?
Actually, this is a and you can see the two the vessels here, and then this one is the pericallosal artery.
Just make sure she's
And,
okay. Yes, please.
It is seen from the 15, 14 weeks of gestation, and you can see sometimes 12 weeks of gestation. There are two, but most of the people they say that this one is the pericallosal artery, but this one, the inner one is the pericallosal artery, and I think the baby here you can see, and here it is quite difficult to see, and then I reduce the volume like this, and then it is quite clear to see that here you can see, right? So if you are originally like this, it is it's quite difficult to understand what is what, right? However, what I said is only the look at the B plane here, the B plane, and then adjust the here, and then we use the volume. Use the volume like this.
Beautiful.
Then you can see the completely beautiful.
How about that? And then when we're in the sub-menu, we can then change to our background if we want to have a cool blue-like background.
Yeah.
And then if we find that that's very busy, we have the option of increasing the power threshold and writing out some of the echoes just to make it slightly sharper. And then we can change our light source when we're adding that. That's beautiful, this is good.
And also you can see the silver color.
Okay, so move on to our next patient.
Okay.